I'm Dr. Greg Kalamkarian, a medical oncologist and professor of medicine at University of Michigan. And today we're going to talk about lung cancer risks and epidemiology. First, we're going to review the risk factors that cause lung cancer with a focus on tobacco smoke. And then we will review the epidemiology of lung cancer, including the impact of race and gender on both incidence and survival. So lung cancer is the most common cause of cancer-related death in the world, and also the leading cause of cancer-related death in both men and women in the United States. Each year, more Americans will die from lung cancer than from colon, breast, pancreatic, and prostate cancer combined. So lung cancer is a very large public health problem. Our pre-lecture question, which we'll come back to for the answer at the end of the lecture, is which of the following is true regarding the incidence rate of lung cancer in the United States? It's highest in people between ages of 50 and 60. It's higher in women than in men. It is highest in African American men. It is higher in African American women than in white men. The second question, the lung cancer specific mortality rate in the United States is now declining. What is the primary reason for this decline? The development of filtered cigarettes, the decreasing prevalence of tobacco smoking, the increasing popularity of mentholated cigarettes, the introduction of low-tar cigarettes, or the increasing use of lung cancer screening. So we'll come back to the answers for those questions at the end of the lecture. So what are the risk factors for lung cancer? Well, the major risk factor for lung cancer is tobacco smoke, as seen on this cross-sectional CT image, where the arrow labeled effect is pointing to a tumor in this person's right upper lung, while the cause arrow is pointing to a cross-sectional cut of a pack of cigarettes and a Bic lighter. So the high-risk populations for development of lung cancer are primarily smokers and former smokers with a clear-cut dose-response relationship. The more one smokes, the higher the risk of developing lung cancer. Other inflammatory lung diseases are also risk factors for lung cancer, including chronic obstructive pulmonary disease, such as emphysema, interstitial fibrosis, and multiple autoimmune disorders that can cause scarring within the lung. A number of occupational exposures have been linked to lung cancer risk, including asbestos, silica, radon, mainly seen in miners, and then a few less common occupational exposures. Prior lung cancer or prior head and neck cancer, mainly related to tobacco smoking, are also very high risk factors for lung cancer. So this slide illustrates the relationship between the prevalence of cigarette smoking and the lung cancer mortality rate in both men and women. We can see across the bottom of the slide is the time element starting at 1900, when tobacco smoking was not very prevalent, and the risk of lung cancer death was very, very low. Over time, as the prevalence of smoking rose, we see that after a temporal delay, the lung cancer mortality rate also began to rise. Initially, men were the ones who were doing most of the smoking, predominantly those who got hooked on cigarettes in the early 1900s, particularly during World War I. And then during World War II, women went into the workplace and became more independent and also began to smoke. And we see that 20 years later, the mortality rate of lung cancer began to rise in women as well. As the smoking prevalence began to decline in the 1960s and 70s, we see that after another delay, the incidence of lung cancer, at least in men, began to decline. Thanks to initiatives by the tobacco companies, such as the Virginia Slims campaigns, the lung cancer mortality rate in women continued to rise and only recently has begun to fall. So lung cancer is a smoking-related disease with 85 to 90% of patients having a history of smoking. This slide illustrates that approximately 50% of people are now former smokers who develop lung cancer. Only about 10 to 15% of people who develop lung cancers have never smoked cigarettes. So the median age at which lung cancer develops is around 70 years old. So it is predominantly a cancer of the elderly. We see that there is a gradual increase up to about age 70, and then a slight decline in the incidence of lung cancer. On this slide, we see the incidence of lung cancer by gender, with males being the top row of filled-in squares, and females being the bottom line of filled-in diamonds. We see that the incidence of lung cancer in men has been falling since about 1985, while the incidence in women had been gradually rising and has now plateaued and just begun to decline. The line indicated by the empty diamonds on this slide is the male to female ratio, and we see that that also has been declining as the incidence in men has decreased and the incidence in women has gradually risen. So that is now a little bit below 1.5 men per every woman who develops lung cancer. The survival of lung cancer also varies according to gender, with men doing significantly worse with lung cancer than women. We see both the 2-year and 5-year survival rates laid out here, with women in the open boxes or triangles and men being indicated by the closed boxes or triangles. And we see that the survival rates for men are lower than women at each time point. And this is a consistent finding, not just in lung cancer, but across most of our cancers. When we look at race and compare Caucasians to African Americans, we see that for women, which are the bottom two lines on this graph, the incidence of lung cancer is similar in both Caucasians and African American women. However, in men, African American men, as indicated by the blue line on top of this graph, clearly have a higher incidence of lung cancer than white men do. When looking at survival and evaluating survival by race, we see that both the 2 and 5-year survivals are better amongst whites than they are amongst African Americans. And this difference seems to have widened in the past couple of decades, with a poorer survival in African American populations. So coming back to our initial questions, which of the following is true regarding the incidence rate of lung cancer in the United States? It's highest in people between 50 and 60 years old. It's higher in women than in men. It's highest in African American men, or it's higher in African American women than in white. We say that the correct answer is that the incidence rate is highest in African American men, who have a higher rate than Caucasian men. But both groups of men do have higher rates than women do, with African American and white women having similar incidences of lung cancer. Second question, lung cancer specific mortality rate in the United States is now declining. What is the primary reason for this decline? And we see that the correct answer is the decreasing prevalence of tobacco smoking, because the prevalence of tobacco smoking very clearly mirrors the incidence and mortality rates associated with lung cancer, since 90% of people who develop lung cancer are tobacco smokers. We're hoping that the increasing use of lung cancer screening will also lead to a decline in mortality. However, this has not yet come to pass. So the take-home points from this lecture are that lung cancer is the number one cause of cancer-related death both in the United States and in the world, that tobacco smoking accounts for 85 to 90% of all cases of lung cancer. Smoking cessation is the most effective way to decrease lung cancer incidence and mortality. And lung cancer incidence is higher in African Americans and in men in general. Well, I want to thank you for your time.
I'm Doug Ehrenberg, Associate Professor of Medicine at the University of Michigan Medical School in the Division of Pulmonary and Critical Care Medicine. My clinical practice and interests are focused on lung cancer, and in this lecture I'm going to be talking about lung cancer screening. The objectives of this lecture are to come away with an understanding of the history and the rationale for current lung cancer screening guidelines, and in that recognize the importance of our ability to measure lung cancer risk, and with the patient be able to discuss the risks and benefits of screening with people who are at risk for lung cancer. So we'll start with this question, and I want you to think of a hypothetical screening test. Which of the following findings would support the use of this hypothetical screening test? So A, a screening test which leads to improved 5-year survival of screened patients from 30% in the control group to 80% in the screen group. B, a cancer screening blood test which detects more cases of cancer it is intended to find. C, a cancer screening test which finds more cases of early stage disease when compared with a control group. Or D, a test for which the mortality from the screened disease is 1.6% in the screen group and 1.9% in the control. So we're going to start with the historical perspective. And for some 30 years, cancer screening recommendations were based on statements made by the American Cancer Society as well as the U.S. Preventive Services Task Force. And to put this into context, the U.S. Preventive Services Task Force is a group of volunteers, experts in healthcare, who issue recommendations for screening services and preventive services, everything from how to check blood pressure to when to vaccinate to how and whether to screen for cancer. In 1980, they issued a statement, both the American Cancer Society and the U.S. Preventive Services Task Force issued recommendations that said chest x-rays were not indicated for the early detection of lung cancer, and that people with signs and symptoms of lung cancer should consult their physician. Prior to 1980, it was just assumed that chest x-rays were a good idea for smokers. But as I'll show you later, several studies done in the 1970s showed that chest x-rays did not serve as a good screening test for lung cancer and therefore should not be used for that purpose. In that context, deaths in the United States alone from lung cancer increased from about 117,000 in 1980 to over 200,000 in 2006. So where are we now? Well, recently, the U.S. Preventive Services Task Force reevaluated the available data and came up with this recommendation published in the Annals of Internal Medicine in 2014. And what they said was that the U.S. Preventive Services Task Force recommends annual screening for lung cancer with low-dose CT scan in adults aged 55 to 80 who had a 30-pack year smoking history within the last 15 years if they were quitters. So you either had to be a current or former smoker within the last 15 years, having smoked 30-pack years or more, and between the ages of 55 and 80. And they also recommended that the screening be discontinued once a person has quit for 15 years or more, or, and this is important, develops a health problem that substantially limits life expectancy or the ability or willingness to have curative lung surgery. So where did this recommendation come from? It came from one of the largest studies ever conducted by the National Institutes of Health, the National Lung Screening Trial. And this study was an enormous undertaking. They enrolled 50,000 healthy, and I emphasize healthy, current or former smokers. And again, former smokers had to be quitters within the last 15 years. They had to be heavy smokers, defined as 30 pack years or more. And a pack year is simply 1 pack per day for a year would be 1 pack year. 2 packs per day for 15 years would be 30 pack years, and so on and so forth. So 50,000 healthy current or former smokers between the ages of 55 and 74, and they were randomized to either get annual chest x-ray or annual low-dose CT scan at baseline, then again 1 year and 2 years later. The study was powered to detect a 20% mortality benefit. Primary outcomes also included all-cause mortality, the prevalence, incidence, the detection of interval cancers, the positive predictive value, the negative predictive value, and the stage distribution of lung cancer. Importantly, they also measured quality of life of those involved in the study and even anxiety related to screening tests. This is one of the most well-done, undertaken screening studies ever in history. They also measured medical resource utilization for positive screens so health economists could have a go at the data when the study was completed. And this is what they found. This curve shows, on the upper curve, the number of cumulative deaths from lung cancer in those who were randomized to chest x-rays. In the lower curve, the black curve, the cumulative number of lung cancer deaths amongst those who were randomized to low-dose CT screening. And what you see is that over time, the accumulation of lung cancer death is far greater in the control group than it is in the low-dose CT group, a 20% reduction in lung cancer mortality, exactly what the designers of the study anticipated finding. And this doesn't sound like much, but when you compare it to other screening tests, a 20% mortality benefit is at least as good as, if not better than, every other currently employed cancer screening test that we do. So the screening was done just in these early years, time 0, time 1, and time 2 years. And then look what happened to these two groups as time passed, to the number of cancer deaths. And what you see is the accumulation of excess lung cancer deaths in the control group relative to the low-dose CT group. So if you develop a scorecard from this data, what you get is a balance of benefits and harms, and we should review these in some detail. So the benefit was obvious. If you got screened with low-dose CT, you were 20% less likely to die from lung cancer than if you were screened in the control group with chest x-rays. And I should add that we now know that chest x-rays don't reduce lung cancer mortality at all. So essentially they served as a control group. But to get this 20% mortality benefit, you pay a price. And the biggest price, which is one we'll talk about later, is that a lot of people have lung nodules, and that's what we're looking for in these CT scans. About 36% of participants in the National Lung Screening Trial had a lung nodule that was a false positive. And in some of these people, 2.5%, to be precise, they ended up having a false alarm that led to some invasive procedure, a biopsy of some sort, a bronchoscopy, or even surgery. So that's 25 out of 1,000 people. And 3 out of 1,000 had some major complication as a result of these invasive procedures. So you pay this price to get that benefit. And the biggest price is driven by the finding of false positives in this group. So colleagues of mine did a study to ask, what happens if you look at the entire population of people that were screened in this group? Do they all have the same experience? And this is a table from a paper that they published to show that the experience was very different amongst persons of different risk for cancer. And this paper was actually prompted by an advertisement that they saw in a newspaper out in California, advertising in the bottom row there, the Sequoia Hospital lung cancer screening program. Now, not to single them out, but the Sequoia Hospital thought that they should be offering screening to everyone based on this data who had ever really even come close to having risk for lung cancer, including if you were 40 years old and had smoked perhaps just as little as 10-pack years. The absolute risk of lung cancer in that group was quite low, and therefore the number of deaths that could be prevented in that group was also quite low. And what they found was that to save one life, they would have to screen 35,000 people in that risk group. Compare that with the top three rows. The average participant in the National Lung Screening Trial, that is the person who is about in the mid-range in terms of their risk, a 62-year-old male, current smoker, about a pack and a half a day smoker for 35 years, the absolute number of deaths per 1,000 people in that group is close to 20. If you reduce that by 20%, you get 15.6. So you avert nearly 4 deaths per 1,000 persons. And to save one life, you could screen 256 people. This is, believe it or not, a very, very efficient screening strategy. Well, let's take the person who is minimally eligible for the National Lung Screening Trial. A 55-year-old female, former smoker, a pack per day for 30 years, who quit. That person, if you take 1,000 people just like them, their absolute risk is about 4 of those 1,000 are going to die from lung cancer. Reducing that by 20%, you get 3.2. You take the inverse of that, you get 1,200 people that you need to screen to save one life from lung cancer. And so on and so forth. If you take people who are very high risk, it's a very efficient screening strategy. People who are very low risk, it becomes very inefficient, very costly, and we cannot ignore the risks because the risks are constant across that. I should say the harms of screening are constant across that risk spectrum. So we really want to make sure that we focus this service on people who are at the highest risk for lung cancer. These are the people who can benefit the most from the test. So let's look at it from another perspective. From a population perspective, let's take 1,000 high-risk participants who would have been eligible for the National Lung Screening Trial. We get 3 fewer deaths by screening them. That's good. On the other side, there's the false positives, 365, about 36%, as we said, 25 biopsies, a complication called overdiagnosis, which we can talk about a little bit more, and 3 major complications from invasive procedures. 6 out of 10,000, 0.6 out of 1,000 will die as a result of being screened, not because they had cancer. So you save 3 lives, but you may put somebody in danger as a result of saving those 3 lives out of 1,000 people. On balance, that's a pretty good outcome, particularly if you're one of those 3 people whose life was saved. Now, what if they're a lower risk group? Take 1,000 people who are at very low risk. There, you don't get as many lives saved. In other words, you'd have to screen 10,000 to save those 3 lives. But for every 1,000 that you screen, 3 of them are going to have a major complication, and twice as many will die as a result of screening as will have been saved. So this screening strategy does not work when you take low-risk people. This is true of any screening test. So how do we measure risk? It turns out that there are a number of ways that we can identify lung cancer risk. None of them are terribly accurate, but over time, investigators have developed a number of models, if you will, that can take clinical characteristics of a patient and predict their long-term risk of developing lung cancer. And it used to be just as simple as asking people whether or not they smoked. We now know that that smoking does not equally distribute the risk for lung cancer amongst people who use tobacco. So some tobacco smokers are going to be at far greater risk than other people who smoke the same amount. And our ability to distinguish amongst them is very poor, but it's getting better. And this is a model published by Martin Tamamagi from Brock University in Canada. It used data from the screening trials to look at who developed cancer, who died from cancer, in relation to their baseline characteristics. Things like age obviously matter. Smoking history still matters, but additional factors which we can easily identify up front, including the presence of emphysema, a personal history of any kind of cancer, or a family history of cancer. Race and ethnicity have an impact on individual risk, as does the duration of time that you've been an ex-smoker if you manage to quit. And so all these can be plugged into an equation and give us data on, for instance, down here, you'll see a number that predicts this person's risk over the next 6 years, 1.2% risk of developing lung cancer. So With this in mind, I want you to think about screening biases. And here's a question about how well we understand the biases that are inherent in any study that uses a cancer screening test. Which of the following are true of screening study biases? A, lead time is necessary for an effective screening program. B, lead time bias cannot explain differences in survival. C, length bias can falsely reflect a mortality benefit in a screening program. Or D, more early stage disease in a screen group indicates that the screening modality is effective. So this is a tricky question. Think about that. And we'll come back to that question in a minute. So here's a curve that I like to use to talk about screening biases. And a basic concept of any screening test is that whatever disease you're screening for has some preclinical period. That is a period where perhaps it's detectable with some test, but before it can be detected by the presence of symptoms. Now, every disease also has a critical point, that point during which treatment might still be effective. And an example of a disease for which screening can't be effective is one we call mad cow disease. This is a disease that once you have it, if it can be detected, it's almost universally fatal. This critical point occurs long before the disease can be detected by screening, which is why we worry so much about an awful outcome like mad cow disease. Now, cancer fits somewhere in the middle. Cervical cancer can be detected by pap smears long before a woman will present with signs and symptoms of invasive cervical cancer. That critical point occurs at a time when the disease is still treatable, even preventable. Colon cancer, the same way. Breast cancer is a disease we currently screen for, and there's a lot of controversy behind that, but most primary care doctors would never question the utility of breast cancer screening because we've been trained to believe that screening for breast cancer helps women who are at risk for breast cancer. So cancer screening, the critical point where the disease is still treatable, occurs at a point where it can be detected by screening before it is evident by signs or symptoms of the disease. And finally, for completeness' sake, there are many diseases for which screening is unnecessary. Community-acquired pneumonia. Signs and symptoms of community-acquired pneumonia typically occur at a time when we can still intervene in the natural history of the disease with antibiotics. So think about screening in these terms, and it becomes much easier to understand the biases. So a group of investigators wanted to understand how well internists, practicing internists, and in this case, practicing internists attending a national meeting, how well they understood these biases. So they presented these internists as part of a study with two hypothetical screening tests. One in which no screening was performed. The disease started, cancer was diagnosed based on symptoms at a certain age, and it killed everybody who got the disease. On the other hand, if you have a screening test which can detect that disease earlier, even if screening is not effective, all those people are still going to die at the same time they would otherwise have died. They will just have known they had cancer for longer. What you have here is a screening test that improves survival, but does nothing about the mortality of the disease. This graph depicts why mortality is the only effective measure of the ability of a screening test to intervene in a disease. Survival is a great measure if you have a drug that treats the disease. It is not a good measure of the effectiveness of a screening test because screening will always falsely prolong the survival from the disease. So you cannot use survival as a means of measuring the effectiveness of a cancer screening test. At the same time, there is a bias called overdiagnosis. And here's a graphic example. In the upper part of this figure, you've got 1,000 people with a cancer that's ultimately destined to kill them. 5 years later, 600 of those people are dead, 400 are alive. That is a 40% 5-year survival rate. Imagine now that you have a screening test, but that screening test detects all sorts of cancers that may never have progressed. We call these non-progressive cancers. We also refer to this as overdiagnosis. In this case, those same 600 people are still dead from their progressive cancer, but we've got 2,400 survivors. So 5-year survival is improved because you've detected disease that was never going to otherwise become evident. This is overdiagnosis. Another bias that is inherent in any cancer screening program. And there are concrete examples of this in breast cancer, cervical cancer, prostate cancer, colon cancer, and it is just as true of lung cancer screening, that there are examples of cancers that look under the microscope indistinguishable from the other types of cancer that we worry about that would never have become evident in the lifetime of that patient. So going back to that question, which of the following are true of screening study biases? The correct answer is that lead time is necessary for an effective screening program. You have to have a time during which the disease is detectable before symptoms reveal its presence. Lead time bias cannot explain differences in survival. That is absolutely not true. It is the cause of differences in survival. Statement C, length bias can falsely reflect mortality benefit in a screening program. Nothing can falsely reflect a mortality benefit. So a mortality benefit is the only thing that you can find that can justify the use of a given screening test, and that cannot be faked, if you will, by length bias. And more early stage in a screen group indicates the modality is effective. That's not true. That is an indication of both length and overdiagnosis bias. You have to be able to understand these biases if you're going to discuss the risks and benefits of screening with your patient. And these aren't just theoretical. So let's go back and look at the NCI chest x-ray screening trials, which were conducted in the 1970s. These are huge trials, 3 different trials, each of which enrolled nearly 10,000 patients. 30,000 subjects were enrolled in these screening trials. And in these trials, chest x-ray detected more cases. There was more early stage disease. Survival was clearly improved in the screen group, but there was no difference in mortality. And this is now a clear understanding that chest x-ray is not an effective screening test for lung cancer. It will not reduce the chances of your patient dying from lung cancer. You cannot screen for lung cancer with chest x-rays. So, all this talk about lung cancer screening and understanding why we can employ this in high-risk patients, the 800-pound gorilla is that tobacco cessation is the most effective means to the end sought through lung cancer screening. That is, if we want to reduce the number of people dying from lung cancer, nothing will achieve this end more effectively than getting more people to quit smoking. So where screening has about a 20% effect on lung cancer specific mortality, effective tobacco cessation can cut that risk in a population by up to 90%. So when we try to employ tools that reduce people's chances of dying from lung cancer, let's keep in mind that we have 2 tools. One is more effective and less expensive, but these are complementary tools. They are not either or. They should be used in conjunction. So going back to our original test question, which of the following findings should support the use of the described screening test? A screening test which improves 5-year survival of screened patients. Well, we've talked about that. Survival does not prove that the screening test is effective. And B, a blood test which detects more cases of cancer that it's intended to find. That's prostate-specific antigen. We don't use that anymore because it doesn't reduce prostate cancer mortality. It is not an indicator of the effectiveness of that test as a screening test. And finally, a cancer screening test which finds more cases of early-stage disease compared with a control group. Again, an indicator of length bias and overdiagnosis bias that can be found even in the absence of a mortality benefit. So the only finding that supports the use of the described screening test is D, which is in fact the finding that we got from the lung cancer screening trial, a 20% reduction in mortality of the screen disease in the screen group compared to the control group. And these numbers trip a lot of people up because they look like small numbers, but when you apply them to millions of patients, that 20% reduction is an enormous impact on overall mortality, which is why we should be properly employing lung cancer screening. And that's all I have to say about that. So, in conclusion, lung cancer screening is beneficial for selected healthy, high-risk persons. We shouldn't be screening people who walk into our office with multiple other comorbid illnesses, related to smoking. It's only the healthy smokers that can truly benefit from this. Identifying those at high risk is necessary if we want to do this on a high quality public health level. Our ability to identify risk is critical. And the risk of cancer screening affects everyone. In other words, no matter how high their risk is for cancer, the harms of screening are going to apply to them. So you cannot take low-risk people and expect them to benefit from this potentially harmful test. The only people who justify those harms are those who are at high risk for the disease that you're screening from.
I'm Greg Kalamkarian, medical oncologist and professor of medicine and division of hematology oncology at the University of Michigan. This lecture will be covering lung cancer, clinical evaluation, and staging. The objectives of the talk are to review the initial diagnostic and staging concepts for patients with lung cancer, and to review the staging criteria for patients with both non-small cell and small cell lung cancer. Lung cancer is a heterogeneous disease with multiple histologic subtypes and molecular phenotypes. The staging of lung cancer offers both therapeutic and prognostic guidance. Proper initial evaluation of patients is imperative for appropriate therapeutic decision-making. Our pre-lecture question is: a 63-year-old man presents with shortness of breath, cough, and fatigue. CT scan shows a 3-centimeter right upper lobe nodule obstructing the segmental bronchus, enlarged right hilar, and paratracheal lymph nodes. PET scan shows FDG avidity in the right upper lobe nodule and in the right hilar and paratracheal lymph nodes with no distant metastases. A percutaneous biopsy of the right upper lobe nodule shows squamous cell carcinoma. What is the most appropriate further management of this patient? A. Bronchoscopic biopsy of the paratracheal lymph node. B. Molecular analysis of the biopsy for driver mutations. C. Surgical resection of the right upper lobe and lymph nodes. Or D. Chemotherapy plus definitive radiation therapy. We'll come back to the answer of this question at the end of the lecture. So the workup of patients with suspected cancer of any kind, not just lung cancer, can really be broken down into 3 important questions. What is it? Where is it? And who has it? And from these 3 questions, we then can derive the answer to the last question, which is, what can we do about it? In this lecture, we'll be talking about the first 3 questions, and in subsequent lectures, we'll be talking about the last question with regard to lung cancer. So, pertaining to what is it, it's important to figure out, number 1, is it cancer or isn't it cancer? And then number 2, what type of cancer is it? So, lung cancer is not just one disease. Lung cancer is a group of diseases that have some significant differences between them, not only with regard to their biological behavior, but also in regard to their treatment. So most lung cancers fall into the category of non-small cell lung cancer, which accounts for about 85%. Subclassified as adenocarcinoma, squamous cell carcinoma, or large cell carcinoma. And then there's the entity called small cell lung cancer that accounts for about 15% of patients with lung cancer. And this is a very distinct disease. So adenocarcinomas are the most common subtype. They are associated with smoking, as are all of these subtypes, but they are the most common subtype that is found in people who don't smoke with lung cancer. They are usually peripheral nodules and can have a variety of different growth rates, from some that are very indolent and slow growing to others that can be phenomenally aggressive in nature. The least common subtype of adenocarcinoma is the adenocarcinoma in situ, what we used to call bronchioloalveolar cancer, that grows in a very slow manner in a non-invasive way along the lining of the bronchial epithelium without invasion into the submucosa or deeper tissues. Squamous cell carcinoma is the second most common subtype of non-small cell lung cancer and is very highly smoking related, with about 95% or higher patients being former or current smokers. This cancer usually occurs in the proximal bronchi, and because of that, it can cause symptoms of obstruction of the airway, including cough, hemoptysis, which is coughing up of blood, or infections. It also is the most common subtype to cause cavitation of tumors, which can also lead to an increased risk of bleeding. Small cell lung cancer is a very distinct disease that is decreasing in incidence as the prevalence of smoking declines. It is almost always found in smokers. I've only seen a couple of people in the last 20-25 years with small cell lung cancer who were never smokers. It usually presents as a central mass with involvement of mediastinal lymph nodes. It has a very rapid growth rate and spreads to distant sites very early in its disease course. Because of this, about 70% of people with small cell lung cancer present with stage 4 metastatic disease, and they have a very high rate of brain metastases. Small cell lung cancer is what we call a neuroendocrine tumor. And because of this, people can develop neurologic and endocrine paraneoplastic syndromes that can have effects on their body at distance from the cancer itself. So in addition to the histologic classifications of lung cancer, there now are a number of molecular classifications, particularly of the adenocarcinomas. If we look at this pie chart, we can see that there are a number of subsets that are determined by driver mutations such as EGFR, BRAF, ROS1, and ALK. These 4 driver mutations have FDA-approved therapies that target them, so it's important to know whether or not any of those genes are deranged within the particular tumor, adenocarcinoma. There are other molecular abnormalities noted on here in yellow, MET, RET, and HER2, for which we do have clinical data from case series or small studies that demonstrates potential for clinical benefit, but they are not yet FDA approved. The other subsets listed here, particularly KRAS, which is the most common driver mutation, we do not yet know how to target. So what do we need to look for when we're doing molecular characterization of tumors? Well, we always can do the broad next-generation sequencing that covers 50 or 300 different genes, and that could be useful for determining research protocols and things that are a bit offline that the patient can potentially be eligible for. But in clinical practice, there really are 4 mutations now that need to be tested for because we have FDA-approved drugs that target them. Those are the EGFR sensitizing mutations, BRAF V600 mutation, and then the ALK and ROS rearrangements. So that's the basic minimum that should be tested for as standard of care in our patients. Well, who do you test? Well, we test people with adenocarcinomas and non-smokers with non-adenohistology, so a squamous cell in a non-smoker should be tested as well. And we only are testing stage 4 tumors because there at present time is no role for molecularly targeted therapy in stages 1, 2, or 3 non-small cell lung cancer. As part of the evaluation, one can do further genomic testing with multiplex mutational analyses or next-generation sequencing, but those are primarily to identify targets for clinical trials enrollment on patients. So moving on to the question of where is it, this gets down to staging. Staging is an evaluation of the extent and spread of the disease. By knowing that, we help to guide the treatment decision-making for the patient, and we also can offer general prognostic information for the patient about what the future might hold. The basic workup for non-small cell lung cancer is a complete history and physical examination, a complete blood count, and a chemistry panel that includes liver and kidney function testing. Patient should have a CT scan of the chest and upper abdomen that includes the adrenals and liver with contrast. A PET scan can be done to evaluate for lymph node involvement or for distant metastases. However, in people who already have clear-cut or proven stage 4 lung cancer, a PET scan is really not necessary. CT scan of the brain is usually done, but except in patients who have very early stage 1 or 2 operable non-small cell lung cancer, where it is not cost-effective to do brain imaging. Pulmonary function tests are important for patients who are surgical candidates to make sure they can tolerate a surgical procedure, and also Similarly, patients should be evaluated for cardiac dysfunction. For patients who have pleural effusions, a thoracocentesis, or a drainage of the pleural fluid, can be very helpful because it can help define the stage of the disease by looking for cancer cells by cytology within that pleural fluid. The use of PET scan has really improved the staging of people with lung cancer. As we can see here on this slide, that when we're looking at whether or not patients have mediastinal lymph node involvement, that PET scan performs significantly better than CAT scan with regard to sensitivity, specificity, positive predictive value, and negative predictive value. Importantly, when looking at the positive predictive value here, 90% looks like a very high value. However, 90% is not quite high enough to allow us to rule out a potentially curative surgical procedure. So even if patients have positive lymph nodes by PET scan, they really need to be biopsied in order to document whether or not they actually are involved, because there are other entities that can cause PET positivity, not just cancer. Things like inflammation, infection, or rheumatologic diseases can cause lymph nodes to look positive when they do not have cancer within them. So we always have to pathologically confirm the stage of disease. So the staging system for lung cancer is based on the stage 1, 2, 3, 4 system in the TNM classification, using tumor, node, and metastasis as categories in order to determine the overall stage. Stage 1 non-small cell is a solitary lung nodule isolated within the lung, not extending outside the lung, with no spread to lymph nodes or any other distant site. Stage 2 has a nodule in the lung plus hilar lymph nodes, so lymph nodes at the root of the lung within the pleural envelope. Stage 3 non-small cell lung cancer generally includes patients with lymph nodes that have spread to the middle of the chest into the mediastinum, but also can include tumors that extend directly into the mediastinum or into the chest wall, into local organs. And then stage 4 non-small cell lung cancer is when we have hematogenous metastases to distant organ sites such as the brain, as illustrated here. In more detail, the TNM classification scheme covers all of the different sets and subsets of stage, and the new 8th edition of the AJCC staging manual has gotten much more complex as far as how do we subset the different stages and how do we distinguish the different tumor classifications. With the T stages determined by the tumor size primarily, or tumor invasion. The N stages determined by the level of lymph nodes as far as distance from the primary tumor. And then the M classifications for metastases into either the contralateral lung or into pleural effusions or pericardial effusions or into distant metastatic sites. I'm not going to go into more detail on this, but this you can look over and try to fully understand how this comes about. Most of the distinction in how the stages are determined is based on prognostic significance, not necessarily therapeutic significance of the different T stages and TNM stages. So now we get to the third question of who has it. And this is really based on the characteristics of the person who presents with lung cancer. Because most people with lung cancer are smokers, they tend to have a lot of other comorbid conditions, such as emphysema, heart disease, kidney disease, peripheral vascular disease, clotting disorders, things that really can affect our ability to optimally treat their cancer. We also have to always assess a person's general functional ability, something we call the performance status, and for which oncologists have very discrete scales in order to measure just how functional an individual is. After stage, we know that performance status is the next strongest predictor of how well somebody is going to do with their cancer. In general, people who are doing poorly continue to do poorly, whereas people who do well tend to do better. So we use that in order to judge what treatments can patients tolerate and what the potential benefit of such treatment is going to be. Age is not by itself an absolute contraindication or reason not to do any particular type of treatment. However, it is important to understand that as people age, their reserve does decline, and they do not tolerate toxicities that may arise from particular interventions as well as they would have when they were younger. In general, though, functional ability is more important than age. So an 85-year-old who is up and around is probably a better candidate for aggressive treatment than a 50-year-old who is spending his entire day lying in bed. The last characteristic that's important for determining who has the cancer is the patient's own belief systems, what their philosophy of medical care is, what their acceptance of particular risks and benefits are, and how they weigh those things within their own minds. So it's important as an oncologist to discuss with patients the options that they have, and then to discuss the pros and cons of each of those options, and then to work through with the patient what they wish to do, always remembering to give them a recommendation as well in order to help them guide their own decision making. Lung cancer is a disease that very uncommonly presents in asymptomatic people. Now, with the advent of lung cancer screening, we will hopefully be finding more of these early stage patients. But because it tends to be a disease in which most patients present with stage 3 or 4 disease, they tend to have symptoms. And we see here that the commonest symptoms being fatigue, and then pulmonary symptoms, which makes sense, of cough and shortness of breath, and then symptoms of more extensive disease, such as weight loss and pain from metastatic spread. So small cell lung cancer, as I mentioned previously, is a distinct disease with this distinct workup and evaluation. So lung cancer is also one of the few diseases left in which the TNM staging system is not commonly used. We should begin using the TNM system to evaluate people for lung cancer. But historically and really practically, the treatment is determined based on a 2-stage VA staging system, with limited stage being confined to one hemithorax, or in other words, disease that can be encompassed in a tolerable radiation therapy port, and extensive disease, which is not limited disease, and can involve pleural effusions, contralateral lung nodules, lymph nodes above the clavicles, or distant metastases. Because small cell, it tends to be a more aggressive disease, 2/3 of patients at least present with extensive stage disease and metastases present at diagnosis. The workup for small cell lung cancer also tends to be a little more aggressive because the frequency of asymptomatic metastases is significantly higher. The basic workup includes the history and physical and the basic blood test, as mentioned earlier. And LDH can be obtained because this is quite a good prognostic factor for people with small cell lung cancer, indicating the burden of disease. CT scans of the chest and abdomen should be done on all patients. An MRI scan or a CT scan of the head to evaluate the brain for metastases should also be done on all patients, even if they're asymptomatic neurologically. A bone scan is part of the standard workup, but if a PET scan is done, then one can exclude a bone scan. PET scans are most useful in people who appear to be limited stage by CAT scans and head scanning in order to evaluate for more distant metastases. In patients who clearly have extensive stage disease, a PET scan is unlikely to be of benefit. Bone marrow biopsies are no longer done as a routine workup since less than 5% of people will have bone marrow disease with no other evidence of metastases. And we only do the bone marrow if there are no other metastatic sites and if patients have abnormal blood counts. So let's look at our question that we looked at the beginning of the lecture. 63-year-old man presents with shortness of breath and other symptoms. Scan shows a right upper lobe nodule that is obstructing an airway and enlarged hilar and mediastinal lymph nodes. PET scan shows avidity within the right upper lobe nodule and in the right hilar and paratracheal lymph nodes with no other metastases. A biopsy of the right upper lobe shows squamous cell carcinoma. What is the most appropriate step in further management? And as we mentioned earlier, the most appropriate step is do a bronchoscopic, endoscopically ultrasound-guided biopsy of the paratracheal lymph nodes in order to confirm that they are indeed involved with the cancer. Because if they are not involved, then the patient is a surgical candidate, whereas if they are involved, then surgery is not the best primary treatment option. So determining the etiology of the lymph node enlargement and PET positivity is very important. Initiating treatment just based on the PET scan can lead to an inadequate treatment of a patient. So we need to first determine exactly pathologically what is and what is not involved with the disease. For squamous cell carcinomas, we generally do not perform driver mutation analysis as a standard procedure. So the take-home points for this lecture are that therapeutic decision-making requires an appropriate diagnosis, staging, and patient-physician discussion of options. Staging defines the extent of disease and offers both therapeutic and prognostic guidance. And lung cancer is not one disease. There are histologic and molecular subtypes that define distinct phenotypes with differing biological behaviors and differing therapeutic options. Thank you for watching this video. So I'm Greg Kalamkarian, professor of medicine at the University of Michigan, and this lecture is going to cover the treatment and overview and surveillance of patients with lung cancer. The objectives of this talk are to review the stage-specific goals of care and the treatment options for patients with non-small cell and small cell lung cancer, and to review the recommended surveillance after definitive treatment of patients with lung cancer. The care of patients with lung cancer involves a multidisciplinary team of providers, frequently involving radiologists, pathologists, pulmonologists, medical oncologists, radiation oncologists, thoracic surgeons. Although there are guidelines for the management of patients with lung cancer, all decision-making must be individualized based on the patient's performance status, comorbidities, and their own goals of care. The appropriate diagnostic and staging procedures are required to allow for optimal therapeutic decision-making. So we'll start with a pre-lecture question. In which of the following patient scenarios is treatment given with palliative intent? An 81-year-old with stage 2A non-small cell undergoing surgery, a 42-year-old woman with an EGFR mutant stage 4 non-small cell lung cancer on erlotinib, a 66-year-old woman with limited stage small cell lung cancer receiving chemoradiotherapy, or a 75-year-old man with stage 3 non-small cell lung cancer on chemoradiotherapy. And we'll come back to this question at the end of the lecture and talk about the answer. So we'll start off with non-small cell lung cancer, just giving an overview of the treatment by stage. Of note, all of these stages and treatment strategies are taken into more depth in other lectures within this course, which I think you should be referred to if you have an interest in knowing more. So for stages 1 and 2 non-small cell lung cancer, that's disease either confined to a nodule within the lung or a nodule in the lung, including local lymph nodes within the hilum of the lung. Surgery is the treatment of choice, and the goal of treatment is to cure the patient of the disease. The primary surgical procedures are lobectomy or, if necessary, a pneumonectomy, and we know that that type of procedure is better for long-term outcomes than lesser resections such as wedge or segment resection. The surgeon needs to sample the mediastinal lymph nodes at the time of surgery in order to give optimal staging information, as well as to guide us as far as whether the patient needs any further therapy, such as adjuvant chemotherapy. We know that post-operative or adjuvant chemotherapy does improve survival in people with completely resected stage 2 or 3 non-small cell lung cancer. Overall, the 5-year survival rates, which essentially is a cure rate in this disease, for stage 1 disease is 60 to 70%, and stage 2 disease is 40 to 50%. You'll notice that these numbers are not as high as we would like to see for early stage disease due to the general aggressiveness and variability of spread of lung cancer compared to some other common tumors such as breast, colon, or prostate, where these stage-specific survivals are significantly higher. For people with stage 1 or 2 disease, there are a number of contraindications to primary surgery. If the stage is higher due to hematogenous metastases or malignant pleural or pericardial effusions, that would be stage 4 disease. If there's biopsy-proven mediastinal lymph nodes, that would be stage 3 disease, or invasion of vital structures, such as the spine or the heart or the esophagus. That also would be stage 3 disease. If people are unable to tolerate surgery, then we call that medically inoperable. And in that situation, the primary treatment would be definitive radiotherapy or stereotactic body radiation therapy or radiofrequency ablation. Again, the goal of these interventions is to achieve cure. For people at stage 3 non-small cell lung cancer, generally meaning that we have spread to the mediastinum, in lymph nodes, or we have invasion of the tumor into local structures, the goal is still cure. Most people are treated with concurrent chemotherapy and definitive radiation therapy, though some people can be considered for chemo with or without radiation, followed by surgery. Immunotherapy after chemoradiation may improve outcomes, and we'll talk a little bit more about that. And in this situation, with multimodality therapy, chemo, radiation, plus minus surgery, the 5-year survival rate is generally around 15 to 25%. For people with stage 4 non-small cell lung cancer, this is a little bit of a different story. Here, the goal is to improve quality of life and quantity of life. This is not generally considered a curable disease. Systemic therapy is the standard treatment, though radiation and surgery can be used for palliation if necessary. Molecular therapy for tumors that harbor driver mutations, such as EGFR, ALK, ROS1, or BRAF abnormalities, leads to a very high response rate of 60 to 70% and can be very beneficial for those patients. Chemotherapy only benefits patients who are fit, patients with a good performance status of 0 to 1 and perhaps 2. Response rates with chemotherapy are lower, about 20 to 30%. Immunotherapy has a clear clinical benefit, and we have a lecture later in the series on the immunotherapy for non-small cell lung cancer. It talks about the scenarios where that is useful. All patients undergoing treatment for stage 4 disease need to understand the potential benefits and the potential risks in order for them to make good decisions about how aggressive they wish to be with their care. The 2-year survival rates for stage 4 non-small cell lung cancer are about 20%, and 5-year survival rates are generally less than 5%. Though this is an evolving field now with the molecularly targeted therapies and immunotherapies, we are seeing more longer-term survivors, though cure remains elusive. In general, treatment by stages is that for stage 1 patients, surgery is generally recommended. A few of these people with larger stage 1B tumors may be eligible for adjuvant chemotherapy, but most of these patients, adjuvant chemotherapy has not been shown to be beneficial. For people with stage 2 disease, surgery with adjuvant chemotherapy afterwards is the standard of care. For the majority of people with stage 3 disease, the treatment is chemoradiation in a definitive manner, perhaps with consolidation, either chemotherapy or immunotherapy. Surgery can be used for some small subset of people with stage 3A disease who the surgeon thinks they can get a good surgical margin on. For people at stage 4 disease, in good performance status, we have a number of options now with chemotherapy, immunotherapy, or targeted therapy. And with that, we are seeing some longer-term survivors, though the overall 5-year survival rate remains quite low. For people with poor performance status and stage 4 disease, generally the best treatment is palliative care, unless they happen to have a particular driver mutation in which the potential for response and improvement in their function is higher. Overall, the 5-year survival rate for people with non-small cell lung cancer, including all stages, is only about 18%. And this is relatively low because the majority of people present with stage 3 or 4 disease. For small cell lung cancer, this is a different disease and is treated somewhat differently. Small cell is one of the few diseases left where we don't generally use the TNM classification for staging, though it can be utilized and does correlate with prognosis. We generally utilize limited versus extensive stage. Limited stage is when the disease is confined to one hemithorax, with a mass in the lung and lymph nodes. And The goal here is cure. This is similar to stage 3 non-small cell lung cancer, where concurrent chemotherapy and early thoracic radiation therapy is the standard of care. With high response rates, 80 to 90% of people will have good shrinkage and improvement in their symptoms. We do use prophylactic cranial radiation because it does improve survival, knowing that without radiation, about 60% of people will develop brain metastases at some point in their disease. And here, the 5-year survival rate, or the cure rate at this point, would be about 20 to 25%. So we are curing some people, though clearly not as high as we would like to see. For people with extensive stage small cell lung cancer, the goal is palliation. This is essentially stage 4 small cell lung cancer. General treatment is combination chemotherapy, which does improve and prolong survival. There are also high response rates, so most people do feel better with treatment and have significant improvement in their symptoms. However, it is not a long-lasting duration of response. Thoracic radiation can be used after chemotherapy and may improve survival by decreasing intrathoracic complications. For management of the brain, we can either do close MRI surveillance for brain metastases and then treat them sooner when they're still in an asymptomatic stage, or one can do prophylactic cranial radiation or PCI, though now we are favoring MRI surveillance as a strategy. The 5-year survival here is very low, and 5-year survivors are rare. Overall, for small cell lung cancer, the 5-year survival rate is approximately 5% because the majority of people, about 70%, present with extensive stage disease. So now we'll talk about how we do surveillance for people who've been treated for definitive therapy, meaning potentially curative therapy with either non-small cell or small cell lung cancer. There's actually very little data to drive what we do in this situation, as there are very few studies of surveillance and what the benefits are. For the first 2 or 3 years, recurrence is the biggest risk, and then beyond that, the biggest risk becomes the development of a second primary cancer. Vast majority of these people are smokers, and whatever caused them to get their first cancer, tobacco carcinogens, can cause them to get a second cancer, so the second primary rate is quite high, and screening scans can improve survival. So for early stage non-small cell lung cancer, we recommend that people undergo clinical evaluations and CT scans of the chest every 6 to 12 months for a couple of years. We can do that more frequently in people with stage 3 disease who have a residual abnormality where the risk of recurrence is higher. After 2 years, then doing low-dose screening CT scans of the chest is good annual follow-up. All patients should be encouraged to stop smoking because people who stop smoking do better and have lower second primary rates. PET scans and MRIs of the brain do not have a role in the follow-up of people with non-small cell lung cancer. For people with limited stage small cell lung cancer treated with curative intent, again, clinical evaluation and CT scan done a little more frequently, every 3 to 4 months for a couple of years, and then every 6 months until the 5th year. And beyond that, you've pretty much are cured if small cell hasn't recurred. And at that point, you can go into a screening low-dose CT scan on an annual basis. All new lung nodules that develop in people who've had small cell should be treated as a second primary, and surgical evaluation should be considered for these individuals. Smoking cessation, again, is necessary in order to try and improve outcomes, and PET scan is not indicated in the surveillance of people with small cell or non-small cell lung cancer. So taking care of people with lung cancer is a multidisciplinary prospect that includes input from many people on many different teams, as you see listed here. The newest addition to this list is the molecular diagnostics labs that give us vital information about how best to manage, particularly our advanced non-small cell lung cancer patients. Integration of palliative care early in the course of the disease can improve overall survival and outcomes. So we'll come back to our lecture question, talking about which of the scenarios is treatment given with palliative intent. So for A, C, and D, all stage 2 or 3 disease, the treatment is given with curative intent, regardless of the potential age of the patient, though we do recommend that patients be fit in order to undergo these therapies. Even though she was the youngest person on the list, the 42-year-old with an EGFR mutant non-small cell lung cancer, stage 4, is being treated with palliative intent with erlotinib. Though it has a very high response rate, it is the disease will eventually recur, and we are not expecting the woman to be cured. So our take-home points for this lecture is that early-stage non-small cell is curable with surgery. Adjuvant chemotherapy improves the survival of people with pathologic stage 2 and 3 disease. Stage 3 non-small cell and limited stage small cell are both potentially curable with chemotherapy and radiation. And for people at stage 4 non-small cell or extensive stage small cell, the goal is to palliate symptoms and improve survival. However, cure is elusive. And chemotherapy, targeted therapy, or immunotherapy does prolong survival and improve quality of life. Thank you.